Awesome. Well, we're live here at Medtech Conference, Toronto. I'm super excited. We have Robert from ResMed. So glad to have you here.
Thank you. Thank you. I'm a corporate strategic advisor to ResMed Corporation.
Awesome. Awesome. We got Randy, our co-host.
Great. So welcome. So what is ResMed? For those who don't know.
ResMed is a company that's based out of San Diego that works in the sleep space. They work on software as a service. They work on a variety of different device, digital medical services solutions is what I would like to call them. Large company, it's publicly traded. I've had the great fortune of working with their government affairs unit for a long time. My area specifically is coding, valuation, coverage, and payment, which gets very legal, it gets very regulatory, lots of work on policy issues. I dabble with FDA, do a lot of work in and out of CMS regulations. And then there's this other organization called the American Medical Association, which actually happens to own the copyright to the medical nomenclature code set that's used for the description of medical provider services, disposable supplies, and medical equipment. And, put that all together and you've got the coding, the valuation, and then the coverage and the payment, for these things.
So basically, you live at this intersection in the United States of the fact that the people who decide to buy an individual medical device or recommend it are not the ones actually footing the bill for the device.
That is correct.
That is correct. Okay.
Yeah, that is correct. And it's, the getting folks from technology companies, ResMed not included, but there are a lot of technologists that, are new to this space and they get the sense, that I can do something digitally that's really, not that different from another world that I happen to be in. I can come and bring a solution that's going to be a better mousetrap, but then they get caught with that because there are a number of different regulatory areas that may not be as, amenable to their idea, whether it be FDA, whether it be CMS with the coverage and payment side, so that's the reality that we're living in. As things have gone digital, there have been great strides made by FDA, by CMS, but there's a really long way that we still have to go to make these things as available as I think some people from the technology side would hope.
So let's talk to people about that journey because you've been doing this for a while.
Yeah.
So a decade ago, if a company like ResMed, it doesn't have to be ResMed, came up with a software algorithm that did better monitoring of somebody using a CPAP machine at night and was able to diagnose additional things, how would they get it to market 10 years ago and actually make some money on it, get paid for it? And what has changed today? What's different or better? Or are we in the same place?
So I'm going to change that a little bit because CPAP is a well-known area. These are durable medical products that exist. There are coverage and payment pathways. So I'm going to go to a different area. Let's say software just generally. 10 years ago, software was something that wasn't really recognized by CMS as a practice expense. And guess what? It's still not. And that's a huge problem. Why is that? Because when CMS looks at a direct versus an indirect, as they like to call it for Medicare Part B, practice expense, they're looking at an allocable versus a non-allocable cost. And under the allocable cost, you have things like medical equipment. Think of it in a traditional sense. When CMS thinks of medical equipment, they're thinking of DME, right? They're thinking of things that
physical stuff.
Physical stuff,
a wheelchair,
exactly.
a walker.
Something, exactly. Something I can touch, right? Something tangible. Right. And when you think of disposable supplies, those are disposable monthly supplies that, again, a doctor is incurring or a practice is incurring on behalf of a patient. Right. And, when you think of another, part of the allocable expenses, it's really clinical staff time. Right. So these are clinicians that are working in the doctor's office, which aren't the ones doing the actual work. They're doing work under the supervision of the doctor. Okay, so those are direct practice expenses. Under indirect practice expenses are things like, the office equipment, for, the people sitting down in the waiting room, the administrative staff time. Those are non-allocable. Well, CMS has this really funky language that they use for something they call computer software, non-allocable. But I've got software as a medical device. Sorry, it's computer software. Non-allocable. And I'm waiting for this to go all the way to the Supreme Court at some point because software as a medical device is no different than hardware as a medical device. Under the law, it's a device. You're still under the Food, Drug, and Cosmetic Act, May 1976. I mean, that's...
So the way they've interpreted it under their current congressional authority, they don't have the ability to go and say we can do it. So either
Correct.
They need to decide they do, or Congress needs to say to them in the new law explicitly, we give you
Correct.
permission and we encourage this.
Correct, which is why you'll see 20, 30, 40 different proposals floating around Congress to create a benefit category for software. Where are they going to go? I'm not sure they're going to go anywhere. Now, you'll have lots of people here that are going to tell you, no, I've got this thing for digital therapeutics, and I've got this thing for something else, and I've got this thing for software, and blah, blah, blah. We've got a Congress that had the benefit, and I say that in the nastiest and most negative way, the benefit of 1 million people dying from a public health emergency, where they had to make short passages of acts to be able to allow telehealth to happen in, a non-rural area, in a metropolitan statistical area. And once a public health emergency died, those waivers died with it. And they can't get their act together to actually have those become permanent. You think they're going to create a benefit category for software as a medical device, which is going to raise the money for healthcare spend by a factor of, I don't know how many millions, if not billions? I don't see it happening.
All right, so let's take a look at that with all of your public policy optimism about DC. And I agree. I would personally not want Congress as my board of directors if I was a federal agency, but you get the cards you're dealt with. What would be a good scenario 10 years from now, realistically, of where we could be in terms of having medical device companies be able to create software for diagnostics, monitoring, and therapeutics that really move the needle, and they're somehow able to get paid for it in a way that reflects the value?
Yeah, this isn't just an issue of Congress, right? Because we have to, not Congress, rather CMS. It's not just a CMS issue, right? It's an issue of all of them. And why do I say that? Because, from a coding perspective, the way that I look at, the entire horizon of a device or a service or a solution like the one that you're describing, it begins with FDA. Does FDA have a, product code that exists that adequately, really specifies this type of thing? From there, that's the beginning. And actually, CMS talks about this in their ambulatory payment classification system. They said, we consider the beginning, FDA, the middle, coding, and the coverage and payment, us, meaning the end, the coverage and payment. So it really does begin with FDA. Why is that important? Is because those products that are created, at that point, that have shown that they're safe and efficacious for human use, those product codes are the ones that are used as the examples to create codes. And the coding becomes an issue with, large medical specialty societies that all participate in the creation of these codes. That's all the CPT editorial panel does. There are hundreds of people that are involved, doctors, lawyers, statisticians, economists, that get together 3 times a year to debate and discuss code change applications that are brought before them that discuss these types of devices and procedures and services and all that.
Awesome. I think this is a bit of a Prince concert. Anyway.
Once a code gets made, then it goes over to valuation. Valuation is yet another organization that takes questionnaires from these medical specialties, which say, here are some invoices, here's economic data. There's a lot that goes into this, right? And at the end of that, it goes to CMS, and that's where CMS says, okay, I've got these benefit categories, and based on the benefit categories that we have in the regulations behind those benefit categories, I can or cannot pay for something. And if I can't pay for something, I can find an exception, which is what they do with software. They don't necessarily not pay for software. They will tell you, sorry, we don't pay for software because it's a non-allocable expense. However, we can crosswalk it. That's their fancy way of saying we can compare it to something that exists that we think is kind of similar. And a great example of that is CPT code 9.
Margin.
Yeah, absolutely. CPT code 92229 for diabetic retinopathy. It's imaging for diabetic retinopathy, right? They came out the first year that code got presented. They said, sorry, we don't pay for licensing fees. We don't pay for software. Squirrel, you get a 0 valuation. We're sending it to contractors. Contractors are those 12 contractors that work around the country that pay the actual payments to the doctors. The contractors came back and said, we know this stuff. We've actually gotten lots of invoices for it. We think it's worth whatever. CMS the following year came right back and said, look, we heard from the contractors and they think it's worth X number of dollars. We think that that's very similar to contact lenses. Actually, you're not, I said a bad word, but I'm not kidding. They came back and said it's very similar to contact lenses, that, a contact lens, some kind of graduation solution. And they said, we're going to crosswalk it to that. And that's what they're paying for to this day, for that code that is a software code.
This sounds like the Sorting Hat in Harry Potter. You know, I think you're Gryffindor.
It very well could be. It's very complicated. There's lots at stake. It's all underpinned by law, lots of regulation, but lots of interpretation as well. We don't always agree on the interpretation. We may not always agree with the policies, but that's a framework under which we're working. So 10 years ago, they didn't pay for software. 10 years later, right now, they still don't pay for software. Your question, to go back to what you asked me, was, what do I see in 10 years? I see
a good scenario.
Yeah, I see FDA really aggressively getting into the more, nuanced area of guidances, which they've done for years now, giving us their current thinking on where AI and generative AI fit in and so forth. I see a lot of other new product codes being created for de novo classification of software as a medical device. I see those going before the CPT editorial panel and getting new codes that really adequately describe these services. And I see all of that going over to valuation, getting a solid valuation that is really encompasses what they're worth. And then I see that going over to CMS, and hopefully they will tinker with their methodology interpretation and start paying for some of those things outright. Or we still live under the crosswalk, but I see more aggressive crosswalking to make sure that these things actually get paid. Or Congress blows up the entire system and then we have, direct payments for these things. I just don't see that happening. Not me. Not in my lifetime. All right.
You have a headache yet?
I just think this is like where you found this guy. He's awesome. I'm
Thank
super
you. That's
excited.
very
I think of Relentless because this is the kind of character habit set for what you've gone through. It's just awesome to have you here today.
It's been fun, and it's fun to be a part of all of it.
It's one of those jobs where I'm glad you do it, so I don't have to. Thank God there's somebody that wants to do it. But the other thing I keep thinking is like, we need a Schoolhouse Rock video for like, I'm just a code.
I know.
They're explaining the
I'm
process.
just a code. I love that. Yeah, I'll be the first one to help sing part of it.
You could be the guy with the
Right. the little bill guy.
Okay,
You
so
know.
one other question that
Sure.
we have is, I'm not on Medicare. I'm not on Medicaid. I'm not on disability. Private insurance.
Yes.
So why doesn't Blue Cross just go do this, or Aetna, or United Healthcare?
Well, sometimes they do, right? Sometimes they pay for CPT codes that are created that CMS has decided to give a zero valuation to and not cover and pay. Sometimes there are new and emerging technology codes that are created, category 3 codes, that absolutely get no valuation, don't get any coverage and payment, and you'll have a private insurer say, hey, we'll pay for that. Even CMS has paid for some category 3 codes. The issue with insurance is that it's very complicated because it's not just Medicare. It's also, under Medicare, you've got Part A, Part B, Part C, obviously Part D in limited forms, it's drugs. And then you've got things like, advanced payment models. You've got things like, value-based care models, right? But then you've got Medicaid. Medicaid has capitated services. They've got contracted services. They've got fee-for-service as well. Then you've got private insurers. Private insurers have all of those, and then even other models under which they work. At every one of those levels, there may be a payment for your, digital innovative solution. The trick is going out and trying to find that, and making the case before the medical directors that it's worthy to get some form of payment.
Medical directors, the physicians who work for the insurer.
Absolutely. It's the same thing with, Medicare. It's the same thing with, with coding. It's the same thing for all of them. Because at the end of this, it's you or your loved one or your kid or your mom or somebody. That's what we're all working towards, right? Is getting them taken care of in the most efficient way where we can save off something horrible, right? That's what drives me. That's what I come to work every day. So
this has been really fascinating, Robert. I just feel like I got like a congressional, open the I don't know
they
what
were
I
just
would,
a little part of the talk. It's mostly regulatory.
Regulatory,
I look at it as regulatory. We got FDA, we got CMS. Those are regulatory.
Just different set of regulations.
Yeah. Congress creates the laws, and then they get implemented, and then you go to regulation, and then you go to policy. But it's all very much symbiotic.
So, what else are you looking forward to catching here at this conference? There's 200 talks. There's 4,000 people.
It's funny. I spent a couple of years in Ecuador. We were talking about that pre-camera. I moved my family there because I was interested in having my girls learn how to speak Spanish. And we just completed our time there, and it was absolutely wonderful. Great country, despite some of the issues that are happening on the coast that we read about,
Yeah.
you know, in the popular media. You know, but there is a big interest in Latin America, and really in Ecuador in particular, in some of the bigger cities, for remote monitoring. You know, and they don't really have, you know, the medical device technology, obviously, that we have in the U.S., but they're very interested in importing it. So I'm actually very curious to, you know, go down there and see what services AdvaMed might have for, you know, those organizations that are looking to implement remote monitoring in a place like South America.
It's interesting because, like, they'll see when we cover different countries, we'll get Brazil, but usually that's about it for, you know, discussions.
No,
and
there are
panels
lots of
around
other
Latin
countries.
America.
There's lots of other countries down there. So Ecuador being one of them.
So you're our last interview of the day. I think it's like our 9th or so. So I'm a little punchy.
You made it to
I'm
the
a little
end.
punchy. I'm going
It's
to
all
give a
good.
recommendation that I think you'll really like.
Okay.
I was watching HBO recently, and they did a documentary series about the economics of the U.S. healthcare system.
Okay.
You wouldn't expect that from HBO, but it was really good. I mean, it just really helped you understand how all these different factors from history and economics have created this crazy situation where the delivery of good care, unfortunately, is somewhat unhooked from the payment for good care. And that, you know, we have these misaligned incentives. And then every time you try and do something, there's so many different entities, state, federal, local, government, private, special interests, you know, which are not, I don't say that badly, they're all doing their own thing, but it makes it so hard to do this change. And ultimately, like, even if you're trying to do the right thing, there's sort of these forces from above and below forcing you to do the wrong things. And you get these zero-sum games of I win, you lose. So anyway, I really recommend this series. It's called The Game of Thrones.
I know that series.
But it is the best education on U.S. healthcare economics I've ever seen.
I think it's the best education on life that I've really pretty much ever seen.
Wow. How do we end on that note?
There we go.
Have a good night.
Thank you for coming
Thank
out.
you, Robert.
Thank you very much. Thanks for having me, guys.
All right, take care.
All right.